Good evening, everyone, and welcome to tonight's webinar, a new class of non-insulin anti-diabetic agents. And tonight we are talking about DPP for inhibitors. We have Professor Merlin Thomas presenting the session. We have Dr. Gary Kilov as one of our panellists, Nicole Frayne, Pharmacist, and Giuliana Murfet, who is a Credentialled diabetes educator also and an endorsed nurse practitioner. My name is Rachel McKeown and I'll be the facilitator tonight, and I'm the Professional Services Manager at ADEA. So thank you for joining us, and tonight's webinar has been sponsored by AstraZeneca, and we very much appreciate their support in running these webinar sessions. I will just get all of the participants to make sure that their microphones are muted, so that's the audience. And please, if you have any questions, to send them through the chat or the question function on your panel of the webinar screen. At the end of the webinar, there'll be a participant survey, and I'll send through the link for that. And then you'll also receive a certificate within the next few days after completing that survey. This session is being recorded, and that will be available also once the session is completed tonight. And the registration for the next webinar, webinar 3 on GLP-1, is available via the ADEA website. So we'll get started with Professor Merlin Thomas, and then we'll have a panel discussion as we go through the presentation, and then we'll have time for questions at the end. We'll just bring up Professor Thomas's slides and we will get started. Okay, over to you.
Great. Well, thank you, Rachel, for that introduction, and thank you to the ADEA for the opportunity to provide this presentation today. It's very timely that we're talking about DPP-4 inhibitors because they are not only all the rage as second-line therapy, not only the fastest growing second-line therapy in Australia, but also there's a lot of new and very interesting data regarding their use coming out at the moment, and particularly coming out at the American Diabetes Association. We'll touch on a little bit of that new data as we go. But just to begin with, we're going to talk a little bit about how DPP-4 inhibitors work, how to best get the most out of their utility, and then we're going to go through a couple of cases, much like we did last time, to look at the potential utility of DPP-4 inhibitors under various circumstances which you would find common in everyday clinical practice. Next slide, please. Hello, Rachel. Okay, so one of the characteristics of modern diabetes care is that we've moved away from the paradigm that HbA1c less than 7 is appropriate for everybody. There are some people in whom an HbA1c less than 7 is not appropriate. For example, those who are poorly compliant, those with poor self-care, long-standing diabetes or high risk of hypoglycemia, those with a short life expectancy, particularly those with advanced age, those with marked comorbidity or limited resources. It's often common in our clinical practice to think, well, maybe less than 7 isn't really the be-all and end-all, and maybe an A1C of 7.5 or even 8 may be appropriate in these very difficult and complicated patients. Next slide, please. Oops, there we go, tipping to 7 for that one, and back for the compromise. Okay, next slide. Cool. So the alternative strategy to that is, rather than say, well, in some people I will accept a compromised target, in some individuals it may be possible to avoid those compromises by simply using the right agent. Where patients are motivated, have got good self-care, a long life expectancy, no comorbidity or good resources, honestly it doesn't matter much what you use because they're all going to have relatively similar efficacy. Next slide. I should tip the thing up. Click for me. There we go, standard therapy. And then on the other side, those individuals who are non-compliant, poor self-care, etc., with high risk of hypo, instead of saying, oh, I'll just tolerate a higher A1C and not treat so intensively, it may be in them that alternative agents really have their best and greatest utility, because the absolute risks from side effects, from other issues are so much greater. Next slide. And into that paradigm moves the DPP-4 inhibitors. And so we'll first look a little bit about how they lower glucose levels in diabetes. Next slide. So what happens under normal circumstances is that when we eat a meal, we produce insulin in response to that meal. However, that insulin response is substantially enhanced by a, if you like, an amplification pathway. And that pathway is through incretins in the intestine. Incretins essentially stand for intestinal things that increase insulin. And that was how they were originally devised. The most important of those is made by the L cells of the intestine and is known as GLP-1. GLP-1 binds to a target receptor and helps the pancreas make insulin. In fact, up to 70% of the total postprandial insulin production is made by this amplification incretin pathway. Next slide, please. And for those of you who have seen the article in the ADEA magazine, you will have read this and understood this, but those of you who haven't, it's easy to try and explain how DPP-4s work to your patients by simply thinking of DPP-4s as part of an amplification system. So whereby an amplifier works that a signal comes into a microphone that is on in green, the amplifier being on makes the signal louder, so the output is considerably louder than it originally was. In the same way, the signal coming to the pancreas is glucose or food, and the GLP-1 amplification system makes the body respond to it in a much more amplified way, and so the amount of insulin that's made is considerably amplified. Next slide, please. But the advantage of an amplifier is twofold. The first is that it makes more response to a smaller signal, but the second is just as important, so that if there's no signal coming into the microphone, even if the amplifier is turned on here in green, there is no output. In much the same way as if you are not eating or have no food in your system, there's no signal to stimulate insulin. And so even though GLP-1 may be in your system, there is no more insulin made. And this means that insulin is not made at the wrong times, and therefore the risk of hypoglycemia is diminished. Next slide, please. The other important thing to remember in diabetes is it's not just all about beta cells and their ability to make insulin. It turns out that in diabetes there's also an abnormality of alpha cells, and this is in type 2 diabetes specifically. And that what normally happens is that the alpha cells continue to make glucagon, even though sugar levels are high, or even though you've just had a meal. And this is partly due to reduced incretin effects, hyperplasia of alpha cells, and increased sensitivity to glucagon. And this contributes to the inappropriately increased rate of glucose output, which is characteristic of diabetes. In other words, about 30 to 60 grams a day of glucose is made by our diabetic patients. Their sugar levels are 10, 12 millimoles per litre, and they're making more and more glucose. Essentially, the gluconeogenesis is anarchic. It's not listening to control. It's just doing its own thing, unrelated and unregulated. Next slide, please. What GLP-1 does is actually brings the anarchic production of glucagon under some control, probably through an effect on both beta and delta cells rather than directly on alpha cells. But either way, what happens is that instead of making unregulated amounts of glucagon, the alpha cells come back in line. So anything that increases GLP-1 not only helps postprandial glucose, but also helps fasting glucose as well. Next slide, please. The big problem in people with diabetes is this incretin effect is markedly reduced. In fact, reduced by about half overall. It's probably not because of low GLP-1 levels, but more that the receptors for GLP-1 are down. So you need much, much greater levels of GLP-1 in order to overcome this resistance, which is why you need to increase GLP-1 levels very high to get an additional response. Next slide, please. So in human beings, the big issue is that, can you click that slide for me, see if that animation will work for me? Yeah, there we go. There's Pac-Man, and that's DPP4. And his job is to eat GLP-1. And if GLP-1 is eaten up, it doesn't have a job. And so, in fact, its half-life is very short, only about 2 minutes. And so the obvious solution to increase levels of GLP-1, to increase your incretin effect, is actually just to inhibit Pac-Man. And that's essentially what all DPP4 inhibitors do. Next slide, please. We go next one. Yeah, and they all work in slightly different ways. For example, Saxa and sitagliptin work as competitive inhibitors, like here in green. They look very much like DPP4. Look very much like GLP-1 in red, but they go on and off. Can you click the slide, please? And they go on and off and on and off again of DPP4, so they're always getting in the way. And essentially, that's how they work. Because the green dots are predominantly free of a protein, they are largely cleared by the kidney. And I'll talk about why that's important a little bit later. Next slide, please. A different kind of inhibitor of DPP4 is something called vildagliptin. And can you click the slide, please, for me? Which goes on and then is destroyed by DPP4. And then another one goes on and this is destroyed by DPP4. And that's essentially how it gets in the way. Next slide, please. So the alternative is something called linagliptin, which you can see has very low, in fact, enormously low free levels of the drug, largely because it's mostly protein bound. It sticks on Pac-Man and stays in its mouth. And so very little is free and unbound, which means that people using linagliptin don't need to change their dose in renal impairment. Although they all work in slightly different ways, but work essentially to increase the level of the red dot there, GLP-1, by getting in the way of Pac-Man's job there, DPP4. Next slide. So, for example, a drug like linagliptin will increase levels of GLP-1 roughly 3- to 4-fold higher than normal, which is much higher than the physiological range, and gives a chance for GLP-1 to not only increase, but also increase the incretin effect and improve the production of insulin and the suppression of glucagon. Next slide, please. So when you look at these agents and see how they all work very nicely. But DPP4s on average lower the A1C just about the same amount as every other drug. So about 0.8 compared to all of the other second-line therapies. But the reason that we use DPP4s is much more than just the A1C. Next slide, please. We know that there's comparable efficacy across the class, and so no matter what you've heard people say or drug reps say, certainly there's no difference really between any of them. They all work to raise GLP-1 roughly 3- to 4-fold higher, and they all work to improve A1C somewhere between 0.5 and 0.8%. Next slide, please. So here we're going to go through a couple of cases and talking about DPP4 inhibition. But what we're not going to talk about is how good they're going to work in terms of efficacy, but the reasons that you might want to use it in terms of tolerability, side effects, hypoglycemia, weight, and the other important things that we need to weigh up when we're first considering to do no harm rather than anything else. Next slide, please. So here's Graham again. Graham is 50 years old, he's married with 3 children and works as a taxi driver. His blood pressure is pretty good, he's got a BMI of 30, he's a non-smoker, he's had diabetes for about 18 months, he's got dyslipidemia and hypertension. And otherwise he's doing pretty well in his life. Whoever's on, can we mute someone? Sorry. The A1C is his 7.9 and his total cholesterol is 3.8. He's on metformin, 1.5 grams a day, a little bit of a statin and blood pressure lowering therapy. So here we are, A1C 7.9, taxi driver, 50 years old. Next slide, please. So here are Graham's treatment priorities. In no particular order, he's got a number of challenges. The first, of course, is his A1C, which is elevated. But there are other things that are important for him. Whether the drug's sustainable, his risk of hypoglycemia, the cost and tolerability issues, his weight and issues regarding compliance. Next slide, please. So to open the panel up, Graham's most concerned with his diabetes about his weight loss. And clearly his A1C is high at 7.9, you're going to say he's going to need another agent. So let's see how well will he tolerate a DPP-4 inhibitor and what will it do for his plan to lose some weight and improve his health. I'll open it up to the panel now. That's Gary and Giuliana. Thanks. All right, Nicole. Sorry.
Yep, I'll kick off if that's all right. He's got some issues, as you say. His A1C is about 1% above what it should be, and so we want an agent that's going to get him under 7. He's a UK PDS type patient, in other words, new onset. We don't seem to have any problems with comorbidities, so we'd certainly want him to come down from where he is. Now he's flagged the issue of weight loss. So what we don't want is an agent that potentially could cause weight gain. And DPP-4 inhibitors are weight neutral. So that certainly would be an advantage. He's also a taxi driver, and I know this hasn't been flagged as the main issue, but certainly is there as one of those. So no hypoglycemia is important, and DPP-4s tick that box again. It would be a timely reinvigoration of lifestyle intervention because, as you pointed out, Merlin, the agent itself is unlikely to get him to target. The agent, whichever DPP-4 plus lifestyle intervention, may well get him down below 7. So that will achieve the weight loss, and it'll achieve it safely, particularly in somebody who's responsible for driving other people around. We certainly don't want hypos occurring.
Nicole?
I just wanted and agree that his diet and exercise wasn't optimal, so it was a potential area to improve and working on targeting that HbA1c. So therefore the DPP-4 would complement the messages that we give with the diet and lifestyle to enable the weight loss. So whether it didn't produce the weight loss, it certainly wouldn't confound it by giving him weight gain. So certainly a useful agent to use there.
Look, I probably don't have very much actually to add to what's been said because obviously, yes, as a taxi driver, we certainly want a medication that doesn't put him at risk of hypoglycemia. It's fairly weight neutral, so it's not potentially going to help him with weight loss, which is one of his desired outcomes. The cost of the medication itself, obviously in comparison to other medications around, is potentially a bit more costly, but certainly it fits the profile of this gentleman. I'm not quite sure if you indicate his BMI as well or not.
30.
30, yeah. So, I mean, it seems like quite a suitable medication for him.
Cool. So we're going to cover this issue and I'm going to discuss this weight issue just a little bit more. Just to pass on a message to the panelists that try, if you can, to focus on the highlighted issue that I've highlighted in gold, because almost certainly I'm going to come and cover the other issues, and in this case we're going to move on to hypoglycemia next. But anyway, next slide please. So just as a way of underlining what you've just heard, here's a meta-analysis of trials taking the kind of patient that we've seen here, on metformin, failing metformin, and adding another agent in. If you add in a sulfonylurea or glinide, or even a TZD like Actos, as you can see in the top 3 lines, you can expect within 6 to 12 months a weight gain of somewhere around about 2 to 3 kilos, which of course is incredibly undesirable when, of course, at the same time you're encouraging a patient to lose weight, or at least trying to do so. Equally, if you were starting insulin in this gentleman, you would expect a 2 to 3 kilo weight gain. The real advantage of DPP-4s is that they are effectively weight neutral in trials, and in fact when you're telling a patient to exercise more and reduces intake of food, he doesn't have to worry about hypos, he can just continue on, and therefore it dovetails very nicely into your nutritional and exercise challenges. Next slide please. So here's just an example of a standard trial where you take some patients on metformin, add one, here is on Glyzer, a DPP-4 inhibitor, or add a sulfonylurea, and you can see very clearly your choice of agent has cost you somewhere around about 3 kilos. Next slide please. Similarly, in this trial using linagliptin against the sulfonylurea glimepiride, you can see how quickly within 6 months the glimepiride is put on 1.5 kilos, and that's been maintained for a couple of years, whereas those on the linagliptin have seen a gradual decline in their weight. And this again is incredibly advantageous when in someone like Graham, a top priority is weight control. Next slide please. But of course there's another top priority as well in him, and as Gary has mentioned already, he's a taxi driver, and his lifestyle and future really depends on having no hypoglycemia. So again, to the panelists, again, to reinforce, can you say something about the opportunities of using DPP-4s in people who are vulnerable to hypoglycemia in this sort of situation? Giuliana, do you want to start? Because you started later. Can't hear you.
I work in a diabetes centre, so often people already come to me already on a DPP-4, and certainly GPs tend to use it as a medication of choice because it doesn't cause hypoglycemia. So, you know, in this patient, it's certainly, as we've mentioned, I guess before, that it's a medication of choice because it doesn't put him at risk of hypoglycemia, and often it's quite symptom-free, so it's a very well-tolerated medication.
Okay. All right. So let's keep moving on. Oh, I can't hear you, Nicole. I can now.
Sorry, I was just going to. Can you hear me now?
Yeah, you're cutting in and out, but we can hear you now.
Hear me now? I was just going to add that benign hypo is definitely a benefit for his driving, and I think it would actually aid in the compliance. So if you gave him something where he thought he might get a hypo, I bet he possibly would choose to be fairly flexible with the dosing. And I think also that tied in with that compliance is the combination products that we can give him that tie in the metformin with a DPP-4 that may also help with all of that. So all in all, I think it's useful.
Well, that's a very good point, Nicole. Okay, next slide, please. So again, the same sort of comparison that I showed you earlier, your choice of second-line agent makes a real difference to their risk of hypoglycemia. Obviously, sulfonylureas and glinides increase the risk of hypoglycemia roughly 8-fold higher than that of a DPP-4 inhibitor. Equally, insulin increases the risk of hypoglycemia. So in someone who's a taxi driver or really anyone who's concerned about hypoglycemia, then using a DPP-4 somewhat mitigates that risk, and that's the real advantage of these agents. They're not better, as you've seen, in terms of A1C, but you can get the A1C down without the baggage of hypoglycemia, and that's their real utility. Next slide. But there is one situation, just to remind you, that that their DPP-4s might be problematic. So, as you can see here, DPP-4s, and by increasing GLP-1, they essentially push your glucose levels down. But the actions of GLP-1 are rapidly terminated once the plasma glucose falls into the normal range. In other words, once the signal is stopped, there's no more amplification, so you can't fall off the edge. Can you click the slide, please? So equally, you go towards the edge and then you always come away from it. And that's the advantage of DPP-4s. As soon as you get close to the edge, you always back away because that's the way they act. Next slide, please. But there's the one catch. If you click this, please. DPP-4s push you down, and then of course you add in a sulfonylurea. Click it again, please. And the sulfonylurea, of course, doesn't care that you're standing close to the edge. So the problem is the combination of DPP-4 and sulfonylurea. Sometimes the DPP-4 works so well, and suddenly sulfonylureas are working at 5 millimoles per litre instead of 10. And so it is quite important when initiating a DPP-4 on top of a sulfonylurea, often to down titrate the sulfonylurea, and sometimes you can stop it almost because it works so well. But if you don't, there is a risk of hypoglycemia initially. And then, of course, the patient comes back to you and said, why are you telling me that this new drug you gave me doesn't cause hypoglycemia? It's made things worse. What were you thinking? Did you go out to a drug company dinner or something? That is the kind of thing that your patients will say, unless you are proactive in saying it's not the DPP-4 that's causing hypoglycemia, but merely it's making it easier for things that cause hypoglycemia anyway to do have their actions. Next slide, please. So here's the other issue for him. He is 50 years old. Now, you would hope he would have a lot of life left in him. And so what you want to do is initiate a drug that not only works now, but it is going to work for another 10 or 20 years, because your management strategy has to run that long. You don't want something to run just a short time. Gary, do you want to comment about sustainability and how well a DPP-4 will keep working for Graham?
Yeah, sustainability and durability of anti-hypoglycemic agents is, of course, a constant area of interest, because we know diabetes is a progressive condition, and as such we escalate and intensify therapy as the diabetes progresses. And as you say, we would hope this gentleman will be around for decades to come. And the durability of the agents we look at are dependent on quite a number of things. If we think about the mechanism of action of incretins, then you could see that certain aspects of action you would expect would remain durable. So the action on alpha cells, the other actions that we haven't spoken about, which I guess we'll talk about more when we talk about GLP-1 agonists, the gut and central acting agents, we would expect actions we would expect to continue. However, much of the action is mediated through that first phase insulin response, and we know that beta cells do decline, and so that aspect of the function of DPP-4s is also likely to decline. So as yet, I think we still don't have the holy grail of the agent that has sustainability forever. So they are sustainable. They are better than agents that rely entirely on beta cell function and that may in fact punish beta cells, such as sulfonylureas, but they may not be quite as sustained. The action may not be quite as sustained as insulin sensitizers such as TZDs, but they do of course have other advantages over something like a TZD. So sustainability is not bad. but we're still awaiting the perfect agent.
Okay. Next slide, please. So what Gary's been talking about here is the transience of the effects of some of these agents, or what's called the exhaustion of it. And you can see from this combination slide where a number of studies of sulfonylureas are being used, you see how beautifully they work for 6 months, but then very quickly they lose their efficacy, and by 2 to 3 years they've lost most of the benefits that they'd initially achieved. And this is often called the Nike effect. So you can see the tick mark over the top of it, and that's exactly what we see with all kinds of sulfonylureas. Whether this is because the beta cells are exhausted from making insulin all of the time instead of just in paroxysms associated with meal, or whether it is the patients that get exhausted because of the weight gain and hypoglycemia and simply stop taking the agents, we don't know. But certainly we see a progressive loss of efficacy when using a sulfonylurea. Next slide. But the real opportunity, for example, is when you look at the long-term efficacy of drugs like, for example, Onglyza or a DPP4 inhibitor, is what you get at around about 12 weeks, is what you see at, 102 weeks. And so the efficacy is essentially preserved over that period of time. There's no evidence of a tick here. It seems to be quite sustained. Next slide, please. Equally, in this long-term study using linagliptin, again, what you see at 12 weeks is what you see at 2 years. And that's really reassuring that whatever the mechanism of it is, it's going to be sustained. They're starting to see some data coming out, 4 or 5 year studies overall, and certainly the results coming out of TCOS, as you'll see a bit later, really suggest that you can get a very sustainable and very useful reduction in A1C. So for someone like Graham, in whom you want a response to keep going, this is very reassuring and makes this management a lot more practical. You put him on an agent, it works. At 12 weeks, it'll keep working for him. And now you can deal with the other issues in Graham's life. Next slide, please. So the other really important thing, of course, is his cardiovascular risk. Graham is 50, but as you can see, he's round, he's male, he's Caucasian, and his biggest risk is having a heart attack or stroke. And the most important priority from your point of view is not to make his A1C lower, but to manage his diabetes in a way that results in the lowering of his cardiovascular risk. Perhaps Nicole and Giuliana might want to comment. Will a DPP4 inhibitor be able to protect this man's heart?
Certainly, from my understanding, there's no long-term outcome studies that show the impact of DPP4s against cardiovascular disease. My presumption would obviously be by maintaining his HbA1c closer to target, then that obviously reduces his risk overall. And then it very much depended on other factors, as in whether he's going to continue to have his sedentary job as a taxi driver, where obviously he sits for long periods or long hours each day. So not 100% sure at the moment.
Okay. Nicole, do you want to comment?
I just wanted to comment that we have to change his focus, because I think Graham's focus would be on hypo and driving and finance, and the CVD risk is obviously the most significant. I guess what I'm interested to know about is like what's happening post-market with the DPP4s. I'm hearing little rumours of things that aren't so good for the heart, so
okay.
Need to be alerted to that.
Sure. Let me go ahead and I'll show you a few of these things. And Gary, don't turn off. I'm going to get you to comment on TCOS for me. See what you think about it. Okay. Next slide, please. So what we know about the DPP4 inhibitors is in the trials done to date, not the long-term trials, but all the short and medium-term trials that were looking at glucose control, overall there was no sense that there was any risk associated with these agents. If anything, the risk of major cardiovascular event was on average around about 29% lower MIs were about a third lower. Stroke was lower, but not significantly. Even mortality was lower. And all of those things really seem to suggest that this strategy is at the very least safe, but also may have some real benefits in terms of patients and their cardiovascular risk. However, the proof really needs to come from clinical trials. Next slide, please. The first of those came out a couple of years ago in the SAVOR-TIMI trial. The SAVOR-TIMI trial took patients at high cardiovascular risk with diabetes, most of whom had quite damaged hearts or previous myocardial infarction, and treated them with either saxagliptin or placebo. They tried to get similar A1C, and the A1C difference between the arms was about 0.3. But as you can see, there was absolutely no difference in death, no difference in non-fatal MI, no difference in stroke with these agents, suggesting that yes, they are safe, but they didn't have any additional benefit beyond glucose lowering with standard therapy. However, as you might be able to see in the right panel, there was this suggestion that hospitalization for heart failure was significantly increased in this trial. We didn't understand why that was, but it certainly appeared to be there. Next slide. The trial with alogliptin took a slightly different approach. Patients who had just had a heart attack within more than 15 days ago, but less than 90 days ago, they'd had a heart attack or unstable angina. And they were then put on alogliptin and placebo. And again, a small difference in A1C was achieved, but there was no particular benefit in terms of death, non-fatal MI, non-fatal stroke. In fact, there was no significant difference in hospitalization for heart failure in this particular trial, although the numbers you can see are about half that seen in the other trial. So although it didn't add up to being significant, the difference in relative terms was about the same. Next slide. So 1 week ago, of course, was announced the trial with sitagliptin or TICOS. And again, that took patients and tried to achieve very similar A1C control. But they were starting patients on average around about 7.2 A1C. And so they were pretty good control anyway. And they were randomized to sitagliptin or placebo. And again, you can see with respect to death, non-fatal MI, non-fatal stroke, absolutely no difference. But reassuringly, no signal for hospitalization for heart failure. So taken together, I'd imagine that you would be able to say, yeah, these are safe for the heart, but there is no signal that they provide any particular benefit. Gary, do you want to comment on these three major trials and how they might relate to someone like Graham?
I think, as you pointed out, that initial promise that we'd hoped for, that there was some benefit, has not been borne out by these outcome studies, but it does confirm their safety. I know that this is a little bit off the brief, but there's also been the concern around cancer and pancreatitis, particularly pancreatic cancer. It was reassuring to see that there was no particular signal there either. So once again, we, I guess, get confirmation of a class of agents that really has placebo-like tolerability, and now we can say it has placebo-like safety. So I think this is an ideal agent for somebody like Graham, and not surprisingly is showing an inverse relationship to sulfonylureas in terms of prescribing. So we're seeing this decline in sulfonylureas as they're being replaced by DPP-4 inhibitors as second-line agents. And I think on the basis of the data we have, that's quite an appropriate switch.
Okay, next slide, please. So the other challenge, of course, is in older patients. And what we are finding is that the average age of people with diabetes here in Australia presenting to general practitioners is well over the age of 66 and heading towards 67, which means there are a lot of older patients. And in those older patients, they present particular challenges for glycemic control. Often we want to compromise on their targets or compromise on their management. But maybe instead of compromising, we could consider no compromise solutions such as DPP-4. Next slide. So here's Pam. She's 71. Her blood pressure's a little on the high side. Her BMI is pretty good, so weight loss is not a priority. She's had diabetes for 18 months, a history of dyslipidemia and hypertension. She's had bladder problems and occasional dizzy spells. But oh dear, her A1C is 8.2 and clearly not on target. Her GFR is slightly low at 55 mils per minute, and she's on metformin, 2 grams a day, a statin and a combination of a angiotensin receptor blocker and a thiazide. Next slide. So clearly her priorities are a little bit different. 8.2, you want to lower her A1C, but there are other issues also that you want to consider, and in particular relating to hypoglycemia, tolerability as well. Weight and sustainability may not be such an issue because you're not thinking about those things for her, but certainly compliance, hypo, and tolerability. Nicole, how do you think she'll tolerate a DPP-4 inhibitor as her second-line choice?
I guess when I look at Pam, although she is an older lady, she looks like she's still quite independent. She hasn't got a lot of comorbidities, so she's really still got good quality of life, and that's where I'd like to keep her. But I did notice that she was having some dizzy spells, so I guess when I look at that, I certainly wouldn't want to give a drug therapy like a SALT that would add to the hypo potential. So a DPP-4 to me would certainly be the option of intensifying without tipping the balance of risk against her.
Giuliana?
Yeah, no, I agree. I mean, certainly with her age and dizzy spells, there is a risk of falls, and research has actually shown that with increasing age and increasing risk of hypoglycemia, there's an increased risk of fractures as well. So we certainly don't want that with this lady at this age. Mm-hmm. Yeah, are we talking about the I can't spit it out, need a drink as well. The other thing I noticed, obviously, is her renal function is declining as well.
We'll address that a little bit later.
Okay, I'll zip it there.
Okay. Next slide, please. So, as you've already mentioned, it's very clear that in the aged, the choice of agent should focus on drug safety. Again, the priority is to first do no harm. She's got an A1C of 8.2, and sure, you want to lower it, but you don't want to expose her to hypoglycemia, heart failure, issues regarding her kidneys, fractures, falls, and drug interactions. And in this sort of situation, strategies specifically minimizing the risk of low blood glucose should be preferred in this sort of situation. Next slide, please. So there are a number of trials that have been done. This one, for example, a trial of DPP-4 inhibitors with linagliptin in patients over the age of 70. And you can see that when you're on normal therapy without a sulfonylurea, there's absolutely no increase in hypoglycemia. The only increase is seen when you use it on top of a sulfonylurea when you're blinded and you don't know to down titrate the sulfonylurea. Clearly, you can avoid that in your clinical care should she be on a sulfonylurea to begin with, but otherwise, without a sulfonylurea or with metformin or overall, there's no increased risk of hypoglycemia by using a DPP-4, and yet at the same time, you're achieving an excellent reduction in hemoglobin A1C. Next slide, please. The other thing, of course, is tolerability, and we know every agent has issues. With sulfurs, there's hypos and weight gain. With SGLT2s, there's the bladder issues and genital infections. With TZDs, there's bone loss and fractures and fluid retention. The alpha-glycosidase inhibitors have got GI effects and bloating and flatulence, and the GLP-1 requires injections, potential effects on the pancreas and nausea and vomiting. And so the real advantage of a DPP-4 is that it clearly is the best tolerated class. It's not the best efficacy. They're all essentially effective when they're taken. But the most likely reason that you take an agent in clinical practice is it doesn't cause side effects. And the reason for the smiley face there is that DPP-4s really have a placebo-like efficacy, as Gary said. Next slide, please. But the other really reassuring thing is data coming out regarding pancreatitis. And so across Saber-TIMI with the yellow bar, Examine with the red bar, and TCOS with the orange bar. Each of the DPP4 inhibitors had numerically higher levels of pancreatitis, but none of those were significant. And the number of events were vanishingly small. So I wouldn't be concerned about pancreatitis with the standard DPP4 inhibitors. And so all of the issues really, heart failure seems to have diminished, pancreatitis seems to have diminished, you don't have hypoglycemia, you don't have weight gain. They're just easier. They're not better, but they're just easier, which essentially makes them better in this sort of context. Next slide, please. So here we go. This is the next issue, and Giuliana touched on this, and she can answer this question now for us. Of course, she has a GFR that's on the slide, down below 60 mils per minute. I think we said about 55. And so there are issues associated with that lower GFR, which influence not only her prognosis, but also the choice of therapies and how you're going to approach it. So, Giuliana, here's the thing that you're going to finish off with, the GFR. What about her renal function? How does it affect her treatment priority?
Oh, I mean, I was just going to comment to say that with DPP4s, they're metabolised and eliminated through different pathways, which generally make it much more tolerable in a person with renal impairment. And whilst there might need to be some precautions and reduction in doses, usually it's tolerated quite well in these sorts of situations. So it's useful again for someone that's ageing, and obviously eGFRs tend to decline with age, which we can't stop anyway.
Cool. We'll keep it going. Next slide, please. So that's absolutely right, that diabetes management is complicated at the best of times, but in patients with renal disease, it can be even more complicated. Those with kidney disease have more risks of hypos, more cardiovascular disease, more heart failure, more cancer, more fracture, more side effects, more dose adjustments and polypharmacy that makes diabetes management difficult. Next slide. And all of the agents really that we would want to use in patients with diabetes have got challenges in patients with chronic kidney disease. Metformin can accumulate. Sulfonylureas cause many more hypos in renal disease. TZDs have marked fluid retention and bone thinning effects, which is more important in patients with renal disease. Insulin causes more hypos. GLP-1s are less tolerable, and SGLT2s simply don't work when you don't have kidney function to excrete glucose. Next slide. So the real opportunity in CKD is, instead of saying, oh, she's PAM, she's got renal impairment, we'll just accept her A1C of 8, that's pretty good, to move to a no-compromise treatment like a DPP4 inhibitor. Next slide. So here's a study, again taking patients with quite severe renal impairment, eGFRs of less than 30, and showing a very nice reduction in hemoglobin A1C with linagliptin that's maximal at 12 weeks and sustained for over a year. But importantly, you're able to lower the A1C in these really challenging patients without increasing the risk of hypoglycemia. Next slide, please. And as you heard Giuliana say, there are differences in this class with respect to their renal excretion. Sitavilda, Saxa, and alogliptin are largely cleared by the kidneys because of the mechanisms that I showed you earlier. They're largely free drugs away from DPP4, getting in the way of Pac-Man getting to GLP-1. And as a result, you need to adjust their doses at various degrees of renal impairment. Linagliptin, on the other hand, has a different mechanism, so has very little renal excretion, so needs no dose adjustment. Next slide. So across the levels of renal function, let's say Giuliana there with an eGFR of around, Giuliana, let's say Pam with an eGFR of 50 or so, she's heading towards a lower dose of sitagliptin at 50 milligrams a day. She would need to use a half dose of alogliptin and a half dose of saxagliptin as well. Vilda would, instead of be using twice a day, you'd use it once a day. With linagliptin, you use the same dose across there. At lower levels of renal function, further dose adjustment may be appropriate for other agents. The fact that you need to change the dose does not mean that they are more dangerous or less efficacious in patients with renal impairment. It's just that you have to choose the right dose. That's really quite important to remember. If you have to adjust the dose with renal impairment, it doesn't mean that this is renotoxic or bad for you. It just means you need to use the right dose to ensure the correct exposure of drug. Next slide. And finally, the last case that I want to mention is DPP4 inhibition in addition to insulin. Next slide, please. So here is Kevin, who presents to his GP. Kevin is 50, his blood pressure is a little on the high side, but he's a big guy. He's 37 as a BMI, and clearly weight loss is his top priority. But he's been through a lot of therapy, 5 years of diabetes, he's failed oral therapy, he's now on insulin injections, and his A1C, oh dear, is 8.2 millimoles per litre. His GFR is excellent, working his kidneys well, and is on metformin and 100 units of insulin a day, and you're still getting nowhere. The real question is, what do we do now? Next slide. So for him, his treatment priorities are all over the place. He's got compliance, he's got A1C, he's got sustainability and weight and tolerability, as well as no hypos, amongst all sorts of other things. Although there's only one slide here, and I'm sorry I've only highlighted one for you guys, but perhaps you'd like to comment on how well a DPP4 inhibitor on top of his insulin might work for Kevin in terms of his therapy. Gary, do you want to comment?
Yeah, so I think we've had a look at the efficacy of these agents, and my first concern would be, would we get him to target? He's a relatively young man. We would probably want to be reasonably aggressive with our management. The DPP4 would work, but one might consider other additions in this context. Cost has been highlighted because currently we don't have a PBS subsidy in addition to insulin, so that could be a problem. I know we're not talking about other agents specifically, but there are other agents that might provide similar benefits but are PBS reimbursed in combination. So I would say that whilst a DPP4 may provide some benefit, it would not be my agent of choice in this particular situation.
Yep. Other panelists?
Yeah, look, I totally agree, and I guess if he's already been through the mill and had lots of changes already made, you know, I would almost be inclined to think it's not the medication of choice just to trial it and then move on yet again, because he would just see it as being a continual failure. And certainly because weight is potentially one of his biggest issues as well. Whilst yes, it's weight neutral, he might lose a couple of kilos, it's certainly not going to improve his overall cardiovascular risk moving into the future, and he is a young person, which is important obviously.
I agree totally with those comments, and again, this is perhaps the best lead into perhaps our next webinar coming up in a month or so's time, looking at the potential utility of GLP-1 injectables, because this may be a guy that you might want to consider that overall. Next slide, please. So in summary, what we have with DPP4s is a very useful class of medication that acts to amplify insulin production post-meal and suppress glucagon production in the fasting phase, which improves fasting glucose levels. But their real utility is not in terms of glycemic control. You can achieve A1C reductions with a range of agents, whether that's a TZD, a GLP-1, or an SGLT2 inhibitor. But the real advantage of them can be shown here in this red box, is that they're all blue. They are neutral in terms of their side effects, their weights, their cardiovascular effects, and their bone effects. So they don't do anything except for lower the A1C. And in our older or frailer or challenging patients, that's exactly what we want, to first do no harm and then get on with the other challenges of diabetes, like diet, like exercise, like foot care, like eye care, like looking at all sorts of other things as well. The real advantage is that they're easy, not that they're better, that they're easy. The real disadvantage of other therapies is that they always come with a cost in terms of side effects, in terms of limitations in certain situations, whereas DPP-4s just simply, you can use them anytime there's a challenge. And my usual response is that when a doctor asks a question of me and says, you know, can I use this drug in this particular situation? For example, asking about an SGLT2 or a TZD, I said every time you think about that question, you should use a DPP-4, because you never have to ask that question of a DPP-4. And apart from dose adjustment in renal disease, their real utility is their simplicity and ease of use. Finally, I'd like to thank all of you for participating in this program. I'd wonder if my panelists want to have any further and final comments about DPP-4 in their practice, and then we'll open it up for any questions that you have there in the audience and out there in Berwick, High Berwick, and all the other places that are listening in tonight.
Thanks, Merlin. So it's Rachel back. So is there any other comments from the panellists before I go through some of the questions we have from our listeners? No?
I'll just really reiterate, I think, the summary, and that is that these agents are so user-friendly. And with each new trial, you know, the TICOS, Examine, Saber-TIMI, we are getting increasing robustness, if you like, of data around these agents, which do increase our confidence. And since most of our patients are going to progress from metformin, it's very important that for that very large number of patients who will end up on a second-line agent, that you know, primum non nocere, first do no harm, and provide an agent that is well tolerated and safe.
Thanks, Gary. Okay, so I'll start with the first question. Is there a role for DPP-4 inhibitors in type 1?
Let me just say that they are not indicated in Australia or indeed in any country as an agent for glucose lowering in type 1 diabetes. They do depend largely on their ability to generate insulin, because they're incretins. And if you can't make insulin, and it's in type 1 diabetes, you might imagine that they have limited efficacy. There have, however, been trials of these agents in type 1 diabetes. And it does turn out that they do lower the A1C about half as much as you would see under a type 2 situation. So that the real advantage, you know, an A1C of 0.3 reduction is not enough for them to be worthwhile. Having said this, the other really exciting question is DPP-4 is in the kidney, and DPP-4 by its inhibition might have important renoprotective effects. And so hopefully we're going to see some data coming through whether DPP-4 inhibition on its own, independent to glycemic control, might actually protect the kidney. And if that turns out to be positive, then maybe they'll look at them in type 1 diabetes, but not at this stage.
Okay, next question. If the panellists can think back to Graham's case, is there any reasons why we wouldn't increase Graham's metformin dose before adding another agent?
So can you just remind us how much metformin he was on?
Let's say it was 1,500 a day.
Yeah, so 1,500 a day, he could be optimized, I guess, to 2 grams. It's certainly not going to get him to target, but there'd be no harm in doing that if he tolerated it. But you'd still be thinking you need to do more.
Going from about 1,500 to, even if you went to 3 grams, you could maybe get 0.1, 0.2 extra. Most of the effect is already there at that dose. And so I would, you know, knowing that his A1C was already high at something like 8.2, you know, I'd agree with Gary that you need to bite the bullet. And sure, you can increase the dose at some point, but I don't think that in this sort of situation, titrating it up, waiting another 6 months with a high A1C is going to do him any favours. you need to move on this A1C, and you can do that quite happily by adding in a second-line agent, often in combination, as Giuliana suggested, that the fixed-dose combination may be a good way to both increase this metformin and add in a new agent. And you can do that very effectively, and he won't even notice. He'll be taking the same tablets as he always did. They look the same, but now they've got a DP4 in them, and that's why they make it easier.
So also thinking about Graham, would you not consider a medication that has shown some weight loss benefits such as Forxiga?
Nicole, do you want to comment on that one?
I was just thinking that Graham's our taxi driver, isn't he?
Yes.
Yep.
So with the SGLT2, I think we get a little bit of increased frequency of urination during start. So whether he would tolerate and comply with an SGLT2 may be something he'd weigh up in comparison, where in a DPP4 he's not going to get many problems at all. Efficacy possibly the same as Merlin said, but it's looking at how he'd manage that with his occupation.
So just to remind all of you that have seen the previous webcast, in the previous webcast we used these same cases, and this was the same case that we had suggested that SGLT2 would be a good choice for Graham. So we don't want to suggest that there's only one choice in each of these particular situations. We've only just looked at the DP4s. If you want more information of why we thought SGLT2s were worthwhile, please go back and have a look at our other webcasts, because we again addressed all of those issues there. But certainly the really exciting thing is that we now have options for Graham. We can say, yeah, we've got an SGLT2, yeah, we've got a DP4. We can try either of those options and expect both to be efficacious. But the DP4 will be better tolerated, absolutely, but the SGLT2 will give us that extra little green up there, as you can see, the extra advantage of weight loss. So if you want to get the weight loss for the extra risk of urination and infections, it's worthwhile. If you want to go something that's very, very simple and simplifies his management, that'll achieve control, and then he can do the rest of the work himself in terms of weight loss and other kinds of things, then a DP4 is your way to go. It makes it a fun situation that you can go either way, and that's what diabetes is all about. You've got now multiple options and multiple solutions to get to the same point.
I was just going to support that in the sense that consumers generally, in actual fact, like choice, and it's wonderful to be able to actually give people, a couple of concepts of these are the medication choices that we have for you, these are the side effects, etc., and allowing them being part of that process of the decision making. And certainly that makes, from my surgery and things like that, more compliance, because they've been involved in that process of decision making for themselves as well.
That's a great point. It's nice to have a number of good choices rather than a number of bad choices. And I think that that's what DP4s and SGLT2s provide. They're both good choices in this sort of situation. And then we can, discuss the, things, the advantages and disadvantages with our patients. And that's really exciting, because that empowers them and gets them feeling as though they're involved in decision making. Whereas before it was just, the choice of a sulfonylurea, which was just horrible, and a DP4. We didn't have many choices. I think the more choices we have, the better it's going to be for our patients.
Yeah.
And there's been another question, and I guess it's preempting the next webinar. So for case study 1 with Graham, do we commence a GLP-1 therapy if there's concerns regarding the weight loss? But perhaps we'll stay tuned for the next webinar.
We'll discuss, Graham, exactly that situation and exactly that case in the next webinar in August.
So tune in. Another question we had, and now I can't remember all the different studies, but can we use the discussed cardiac studies and expect the same outcomes for each of the DPP4 agents? So is there a linagliptin study as well?
Gary, do you want to comment?
So all of the new agents have long-term outcome studies. So you may recall after the Nissen meta-analysis of rosiglitazone, where we really shifted from assessing agents on the basis of efficacy in terms of A1C lowering, the focus has shifted to safety as well. So every agent that's come since then does have to have and does have either published or in process safety outcome studies looking at cardiovascular safety, but also malignancies as well. So yes, so all of the agents will have these long-term studies. I think except vildagliptin, I think they decided that they didn't necessarily want to entertain the US market. But as far as I'm aware, all the other agents have ongoing studies.
So only 3 have been published so far, which were basically shorter trials. TICOS was the longest one and first initiated, and that was just over 4 years. The longest overall will be the trial with linagliptin, which will be nearly 6 or 7 years, and that's a couple of years away yet in terms of getting some data out of. That's Carolina and Carmelina. So there will be all the cardiovascular trials out of all of them eventually. The reason that we've got 3 at the moment is just the way that the trials have been set up. But there will be trials with linagliptin, but as Gary says, probably not with vildagliptin per se. Their strategy was to look at heart failure specifically, and they probably have got burnt with that a little.
We're almost at the end of the questions, so if you can stay tuned for another 5 minutes, we'll keep going through them. So how long would you wait for before determining if the DPP-4 has been effective before moving on to another agent?
I think if we look at the current RACGP guidelines, which really are in step with most guidelines, you know, it's the stop rule. You really wouldn't want to go much 6 months at the absolute outside, but I think for most agents, if you're not seeing a meaningful result by 3 months, you want to be rethinking your strategy, assuming, of course, that the patient is adherent to the medication and there aren't any other confounders. But three months, I think, 6 months at the very longest, very outside.
And I guess the next question is along the similar lines. So as the action of GLP-1 does need active beta cells, what level of HbA1c would you consider would see no benefit using DPP-4 inhibitors?
Well, I don't think that that's entirely true, because you can give this agent as initial therapy, you know, so for example, as monotherapy. It's not subsidised in Australia, but you give it as monotherapy, newly diagnosed patient, and you get an A1C reduction of about 0.8. You can give it to someone with renal failure on dialysis. Every organ is completely kaput, and you get an A1C reduction of 0.8. You can give it to patients who are on insulin already, and you get an A1C reduction of around about 0.8. So I don't think that there is any point in which the efficacy is lost, although you might think it's dependent on insulin. In fact, it still seems to work in patients who are essentially insulin dependent type 2 diabetics. So I would not use that idea that the loss of beta cells implies that these agents won't work. They work very effectively in all sorts of circumstances. Their real advantage is that they work, you know, safely in those circumstances. They're not particularly stronger, but you can use them in all of those, you know, troubling situations that you know are reluctant to use anything else.
There are a couple of other things to remember, and that is that the high, and this applies to all agents, the higher your starting HbA1c, the more robust your glucose lowering effect is. And so the closer you are to 7, almost paradoxically, the less efficacious they seem to be. That's the one thing to remember. The other thing is that it also depends on that particular individual. So for all agents, we have responders and non-responders, and that 0.8 is really a composite figure of the study, but there may be somebody who gets a 1.5 reduction and there may be somebody who gets a 0% reduction. So I think it's something worth trying, but not a set and forget. You try it, you reassess. If you haven't achieved your targets in 3 and certainly by 6 months, you move on.
I agree. I was just going to make the comment that in practice, sometimes it can surprise you that you can start it in someone and have quite a significant effect, and you may not have actually expected it to work that well, whereas you may have other patients where you think that it will in actual fact work and it really has no impact. But so it is always worth a try because of that. Yeah, there are cases that are particularly, it's individual to them, but particularly effective.
Any contraindications or side effects?
Well, as you've heard already tonight, the utility of these agents is that they have few side effects altogether. There is one important contraindication, and that is medullary carcinoma of the thyroid or a familial predisposition towards that. That is because it is known that GLP receptors exist on this particular kind of cancer, and you might consider it to be problematic to be on an agent that increased GLP-1. But outside of that, perhaps someone who had, chronic and active pancreatitis, you might want to consider that this agent might not be appropriate, although there's no evidence for that. It's probably a reasonable thing to worry about. But outside of that, even patients with heart failure, there doesn't seem to be a particular problem. Certainly seen in TCOS, there was no evidence that those in heart failure had any problems with sitagliptin. So I wouldn't see, most of those contraindications that you would see with other agents being a problem with the DP4 inhibitor.
And I've got one very last final question, and it's to do with the gut. So any effects on delayed gastric emptying, increasing satiety, or gastroparesis?
Sadly not.
No.
GLP-1 agonists, as you'll see in the next webinar, clearly have these effects because of their ability to increase GLP-1 levels really to quite very high levels. And that allows it to have very key gastrointestinal effects, which is why you see nausea and vomiting, and also increased gut emptying in patients who are on a GLP-1 agonist. Whereas DP4s don't have any gut effects, which is really quite surprising, but that's simply a manifestation of the fact that they don't really increase GLP-1 levels particularly higher, maybe 3- or 4-fold higher. And that means that they're extremely well tolerated, not just from a gut point of view, from an overall point of view as well.
Any final comments from any of the panellists before we sign off for the night?
So just in relation to the last question, which I think is an excellent one and certainly a good segue into the next segment, and that is that even though you do get an increase in GLP-1 levels, those effects that were described, in other words, the increased satiety, the slowed gastric emptying, actual normal physiological responses. These are not abnormal pharmacological responses. But there is a resistance to GLP-1 in people with diabetes. So GIP levels can actually be increased in diabetes, but the resistance to them means that they're really quite ineffective. So we are seeing part of the effect is in the person with diabetes is that the impaired secretion, but also the increased resistance. So those good effects, which would help suppress some of the hunger that we see, it's very hard for people with diabetes to lose weight, are blunted as part of the very complex pathophysiology that we see with diabetes.
I think we'll sign off there, and thank everyone for hanging around for an extra 15 minutes to answer questions. Thank you to Professor Thomas, to Gary, to Giuliana and Nicole for being on the panel tonight, and thank you all for participating. Remember, the next webinar is open for registration, and also thank you again to AstraZeneca for sponsoring the series. So bye for now, and see you next time.
Okay.
Good night.
Good night.
Good night.